Welcome to the Deep Dive. Today, we're plunging into something truly critical, really cutting edge in medicine. We're looking at using infrared spectroscopy for assessing organ viability in transplantation. Just imagine the stakes here. A donor organ, a patient waiting, and that urgent life or death need to know quickly, accurately, if that organ is actually healthy enough. It's really about giving someone a second chance at life. So our mission today is to unpack the source material you've shared with us. We're drawing specifically from infrared spectroscopy for organ viability assessment. We're aiming to pull out the most important insights, maybe some surprising facts, and definitely the practical side, the implications of this incredible technology. Think of this deep dive as your shortcut, really, to getting informed on this medical frontier.
Absolutely. And just to set the stage, let's quickly define what we mean by infrared, or IR, spectroscopy. At its heart, it's a non-invasive way, label-free, to sense what the tissue is made of, its composition, and its physiology, how it's working. It uses different parts of the infrared spectrum, near-infrared, NIR, and mid-infrared, MIR. Both are involved. The real potential, I think, is its ability to report on things like blood flow, perfusion, tissue structure, detecting water, lipid, protein, collagen content, and even subtle metabolic changes happening within the organ, the goal, to predict how well that organ might function after transplant. Or, crucially, to flag those suboptimal organs that might cause problems down the line.
Okay, so this light fantastic, as it were, how does it actually deliver? Let's maybe start by unpacking near-infrared, the NIR spectroscopy first. What's the basic idea there, and why is that part of the spectrum such a potential game changer when, an organ's fate is on the line?
Well, NIR spectroscopy, it works by exploiting how light gets absorbed by natural chromophores in the tissue. Chromophores are just molecules like hemoglobin that absorb specific colors or wavelengths of light. So because of that, it can continuously monitor blood flow, oxygenation, or even probe the tissue's biochemistry more deeply. Its key advantages are pretty significant. You get deep penetration, maybe 1 to 2 centimeters into the tissue, plus rapid continuous readouts. And there's real potential for miniaturization. Think small imaging devices or little point sensors you can place right on the organ. It's particularly good for oxygenation monitoring, kind of like those cerebral oximeters used for brain oxygen, but adapted for grafts. The downsides, though, well, it can be sensitive to superficial stuff like fat or skin, and its molecular specificity isn't quite as detailed as, say, MIR.
Right, that real-time continuous monitoring piece. That sounds incredibly valuable. Being able to see oxygenation levels live, that could make a huge difference.
Yeah.
Can you give us some specific examples? How is NIR actually being used now, maybe starting with kidneys? There's such a common transplant.
Yes, absolutely. And a key insight for kidneys is that NIR isn't just a lab curiosity. It's proving effective for continuous real-time monitoring in actual patients. Think about knowing an organ's oxygenation, its blood flow, moment by moment, and non-invasively. Studies, like the one by Malakasyodi and colleagues, showed it's well-tolerated in pediatric kidney transplant recipients. And importantly, the NIR readings directly correlated with things like blood flow resistance from ultrasound Doppler, a good sign of organ health. Guidini and others have also shown it works well post-operatively for monitoring. And it's not just in patients. Preclinically, there's been impressive work, too. Malion and coworkers, for instance, they built an invasive NIR sensor, fiber-coupled LEDs and detectors, for pig kidneys. In a pig auto-transplant model where they transplant the kidney back into the same animal, the system had 100% sensitivity for detecting if the artery or vein was clamped, so complete loss of blood flow. It reliably flagged reduced perfusion when they deliberately restricted flow, a potential critical alert system. Interestingly, they found that slower, low-frequency changes in the light intensity signal were actually more robust indicators than the rapid pulses, especially if the animal was moving. And going beyond just real-time flow, Acosta and colleagues used a related optical technique, spatial frequency domain imaging, to look at kidneys during cold storage. They saw that the optical properties scattering and absorption of pig kidneys changed quite a bit over 80 hours of cold ischemia. These wavelength-dependent shifts suggest changes in tissue integrity during storage, and it implies that multi-wavelength NIR could potentially non-invasively detect this kind of preservation injury before the transplant, maybe even predict viability.
Wow, okay, that progress in kidney monitoring is genuinely impressive. But how does this NIR capability translate to, say, the liver? That's another really vital organ. Livers have their own challenges, right? Right. Especially the things like fatty liver, steatosis. How does NIR handle that?
Yeah, for liver transplants, NIR has shown definite promise, particularly in assessing fibrosis that's scarring in the tissue. Sharma and colleagues recently used a handheld NIR spectrometer, scanning fresh human liver samples, biopsy cubes actually. They correlated the spectra directly to fibrosis graded by standard histopathology, and they saw clear differences in how light was absorbed between cirrhotic, heavily scarred livers and normal ones, especially at specific wavelength linked to collagen, like unique light fingerprints showing where the scar tissue is. Their machine learning analysis got about 96% accuracy for spotting cirrhosis and over 93% for grading the level of fibrosis. That's a pretty strong proof of concept for rapid, label-free quantification. Could really help decisions right there in the OR. And on the continuous monitoring side, similar to kidneys, Ibadov and others noted that continuous NIRS with sensors, maybe on the liver surface, can track perfusion and oxygenation in real time. This could potentially alert clinicians to dangerous changes in blood flow during or after the transplant. Early reports even show these liver NIRS signals correlating with biochemical injury markers like AST and ALT levels during reperfusion. Those are enzymes that leak out when liver cells are damaged, so it's like a direct signal of cellular stress. But there are limitations to keep in mind. Signal quality can be tricky. Subcutaneous fat thickness, patient positioning, these can affect it. And NIRS generally can't see deeper structures like the bile ducts within the liver.
Okay, so it sounds incredibly promising for these abdominal organs, kidneys and livers. Is most of the research focused there, or are we seeing applications for other organs too, like the heart or lungs?
That's a good point. You've hit on something there. Infrared viability scoring in heart transplants is noticeably less developed. There are some NIR efforts and even Raman spectroscopy work on heart specimens, but usually for pathology like looking for fibrosis in hearts that have already been removed. Real-time transplant viability assessment, that's still largely experimental for the heart. Standard cardiac NIRS monitors oxygenation during surgery, sure, but it's not really validated as a viability score for transplantation itself. And similarly, lung and pancreas graft monitoring with IR is still pretty minimal. A big challenge often is just physical access, getting the probes where they need to be. So adapting these optical probes for different organs is definitely a key area for future work.
Fascinating. So NIR gives that broader, deeper view, mainly focused on blood flow oxygenation. Now let's switch gears a bit to mid-infrared IR spectroscopy. How does MIR work, and what unique angle does it bring that maybe complements what NIR is doing?
Right. So MIR, mid-infrared, operates in a different part of the spectrum, roughly 2.5 to 25 micrometers, or in wave numbers, 4,000 down to 400 per centimeter. It works by probing the fundamental molecular vibrations, basically how the chemical bonds within molecules wiggle and bend when hit by this specific energy of light. This gives incredibly rich, detailed fingerprints of biomolecules, lipids, proteins, carbohydrates, nucleic acids. Common ways to do this are ATR-FTIR, that's attenuated total Fourier transform IR, and FTIR microspectroscopy. The unique info it provides is really specific chemical detail, like precisely quantifying fat versus protein content. But its penetration is shallow, usually less than 100 micrometers, so it needs direct contact or often a biopsy sample. For organ grafts, its main focus has been quantifying steatosis, that fatty infiltration and fibrosis, because both strongly affect transplant success.
Okay, that chemical specificity sounds incredibly powerful, especially for those liver issues, steatosis and fibrosis. How exactly does MIR zero in on those critical markers? What have studies shown?
Yeah, MIR has shown a real potential here. For liver steatosis, that fatty buildup, which is a major reason organs get discarded, Perez Guaita and colleagues used ATR-RR. They took human liver biopsies right at procurement when the organ is recovered. They found the IR spectra captured the overall lipid composition, the fat profile, and could specifically quantify signals from trihydrosyl, it's the main storage fat. And they found strong correlations between these FTR features and both standard histology grading and more advanced lipid analysis, lipidomics. Their conclusion was that ATR-FTIR could rapidly, like seconds to minutes, classify the steatosis grade right there in the OR, offering a much more objective measure compared to just looking at it or waiting for a Frazee section analysis. Building on that, a more recent study by Coyley and colleagues used FTIR microspectroscopy on frozen liver sections. They measured the total triglyceride content very accurately. They found an excellent correlation with the gold standard chemical assay, which is impressive. And they even identified a specific fat threshold around 250 nanomoles per milligram, above which the risk of the graft failing after transplant rose sharply. So it shows MIR spectra can almost act as a direct viability sensor for dangerous fat levels. It gives these chemically specific metrics, like looking at the peak around 1735 wave numbers, which is a strong signature for the carbonyl group in lipids. Think of it as a barcode for fat. And for liver fibrosis, MIR can also detect collagen through its characteristic amide bands. That gives a direct measure of scar tissue. While maybe less reported specifically in transplant viability studies compared to steatosis, MIR has been used successfully in other liver contexts for fibrosis and even cancer detection.
It's really clear that both NIR and MIR have these distinct strengths, but also unique hurdles. With MIR, that need for a biopsy or a thin section, it does feel like a barrier to the continuous real-time monitoring we talked about with NIR. Is that a fair trade-off?
Okay.
And does it make MIR maybe less applicable for broad organ assessment outside of specialized lab analysis, perhaps for kidneys?
That's generally a fair assessment, yes. MIR in kidney transplants, for example, is just not as well studied. Kidney tissue has fat and protein, sure, but severe steatosis isn't usually the main clinical problem like it can be with livers. Some groups have looked at FTIR, maybe combined with machine learning, on urine or blood samples to detect kidney injury or rejection post-transplant, but not directly for pre-transplant viability. In principle, yes, MIR could quantify fibrosis or inflammatory markers in a kidney biopsy, but it's still a largely open research area. And for heart or lung grafts, MIR viability markers haven't really been reported. So the key limitation for MIR, as you said, is often sample preparation. It usually needs thin sections or homogenates. That currently prevents its use for continuous non-invasive monitoring in the way NIR can be used. So yeah, the current emphasis tends to be NIR for continuous monitoring and MIR for rapid, highly precise lab assays on smaller samples like biopsies.
This technology, both NIR and MIR, sounds incredibly powerful. But maybe to someone listening, it could still sound a bit like, well, magic. What kind of actual instruments are we talking about here? And once you get all this spectral data, how do researchers make sense of it all? It sounds complex.
It can be complex, yeah. Instrument-wise, it varies. For NIR, you often find fiber optic probes. These have LEDs emitting light and detectors picking it up, usually sampling at, say, 4 to 8 specific wavelengths. There are also handheld spectrometers, like the one Sharma used, that scan broader ranges, maybe 600 to 1750 nanometers, and even hyperspectral cameras that create an image where each pixel contains a full spectrum. These devices can range from adhesive skin sensors, kind of like those pulse oximeters, but for tissue oxygen placed right on the graft. TR probes that, in animal studies, have even been stitched right onto a kidney capsule for continuous monitoring over, say, 48 hours. For MIR, you're usually looking at the benchtop FTIR spectrometers. They often have special ATR crystals attenuated total reflectance for analyzing fresh tissue surfaces, or FTR combined with a microspectroscopy used on prepared slides. A nice thing, often, is minimal sample prep is needed, especially for ATR-FTIR, maybe just a drop of saline on a biopsy. Now, making sense of the data, that definitely involves sophisticated signal processing. It usually starts with pre-processing the spectra, baseline correction to remove background signal, smoothing out noise, normalization to make different samples comparable. Sometimes taking derivatives of the spectra helps highlight features. Then, advanced multivariate analysis and machine learning models are really key. Techniques like partial least squares, PLS, or neural networks support vector machines. These algorithms are trained. They learn to associate patterns in the spectra with the ground truth, usually from traditional pathology, like the fibrosis grade. That liver fibrosis study by Sharma, they got around 96% accuracy using a combined machine learning approach. These methods are absolutely crucial for filtering out noise, like motion artifacts if you're monitoring a live subject, and for extracting those subtle but meaningful differences hidden in complex, overlapping spectral signals.
Okay, so we've covered the what's and the how. Let's get to the bottom line. For you, the listener, what are really the biggest pros and cons here? What are the main advantages and disadvantages of using IR spectroscopy for checking out organ viability?
The advantages are quite compelling, I think. First, it's non-destructive. You're not damaging the tissue you're measuring. It's rapid. Readings can often be taken in seconds or minutes, and it offers that potential for real-time assessment. NIR sensors especially can continuously monitor graft perfusion, oxygenation without needing invasive blood draws. The instruments themselves can be miniaturized, handheld, wearable potentially and importantly, integrated into organ perfusion machines, the systems used to keep organs alive outside the body before transplant. These spectral methods directly probe the molecular makeup collagen, lipids, water, offering objective biomarkers much faster than traditional methods. Imagine classifying fibrosis in seconds with a handheld NIR device versus waiting for frozen section pathology. And MIR brings that chemical specificity, allowing precise quantification of things like fat content in the liver, which can really predict steatosis risk accurately. But there are definite limitations we have to acknowledge. Tissue optics themselves can be tricky. Blood, fat accumulation, edema, or swelling. These can obscure or alter the signals. NIR measurements in deeper or thicker organs are limited by light scattering. Things like donor obesity or even how tightly the graft is stretched can affect the readings. Sharma noted that skin fat thickness affected liver NIRS, for example. And MIR methods, as we discussed, usually need direct contact or a biopsy, limiting their fully non-invasive use. Both techniques produce complex spectra. They need sophisticated calibration, and results can sometimes vary with temperature or between different instruments. That's a challenge, clinically. Most IR techniques are still largely experimental. We don't have many large-scale clinical trials yet, and getting the gold standard comparisons, like biopsies, isn't always easy or immediate. And finally, it's crucial to remember these IR signals are often indirect proxies. Okay, a strong collagen band suggests fibrosis, but linking that directly to the organ's overall functional viability, how well it will actually work long term, that still needs more rigorous validation through extensive studies.
That's a really critical point, bridging that gap between the spectral signal and the actual long-term function. So, looking ahead, connecting this to the bigger picture, what really needs to happen for IR viability scoring to become, a standard tool? Something doctors rely on routinely in transplantation.
Well, the absolute critical step is robust clinical validation. We need large-scale prospective studies, studies that directly correlate these NIR or MIR scores with actual long-term graft outcomes in human transplant recipients. That's number one. Alongside that, standardization is essential. We need to develop standardized spectral libraries, databases for different organs, different pathologies, different conditions. This would dramatically improve the robustness and reliability of these techniques, allowing comparison across different hospitals and instruments. Technologically, continued advances are also key. Things like quantum cascade lasers for MER or maybe improved NIR detectors. These could boost sensitivity, allow for smaller devices, making them more practical in busy surgical environments. Multimodal approaches also look very promising. Combining IR with other techniques, maybe fluorescence or Raman spectroscopy, could give a much richer, more complete picture. Sharma's group has shown this kind of synergy in heart tissue studies. And finally, I think a major frontier is seamless integration. Specifically, building spectroscopy capabilities directly into organ perfusion machines, those normothermic or warm perfusion systems that are becoming more common. We're seeing early steps like portable Raman probes being tested on the perfusate, the fluid circulating through the organ, to assess liver viability. That hints at a future where IR data and perfusion metrics are just automatically fused together, giving a really comprehensive viability assessment.
So wrapping this up, what does this all mean for you, the listener? We've taken a pretty deep dive into how infrared spectroscopy, both NIR and MIR, is genuinely starting to revolutionize how we assess organ viability. It really feels like a shift, moving away from somewhat subjective visual checks towards objective, real-time, molecular-level insights, helping doctors make faster, hopefully more informed decisions that could save lives and really improve transplant outcomes.
Exactly. The promise here is huge, particularly for expanding the donor pool. This kind of technology could give clinicians the confidence to rescue those marginal organs, ones they might currently discard due to uncertainty about their condition. Now, the journey from exciting research to widespread clinical use, it definitely still has hurdles, as we've discussed. But the potential impact on patient lives, it's truly significant.
Thank you for joining us on this deep dive today, and here's something for you to perhaps mull over. As these technologies get smaller, more portable, maybe even integrated into everyday medical devices, how might they not only improve something as complex as transplantation, but maybe change how we monitor and understand our own health in real time, perhaps long before a major health crisis even hits?